This is Roberto Bergamaschi from New York. Thank you for inviting me. As you can see, on the first slide, I will speak about the situation in New York during the past months in relation to the COVID-19 pandemic. This second slide is showing you the display that I would be seeing on my way to work. And you can still see a few cars. This is really a few cars from New York. This is essentially, namely, essential workers. And the signs are saying, stay home, stop the spread, save lives, flatten the curve. These are images of the city that never sleeps, that appears like a ghost town. The governor of the New York State has organized a number of hospitals that would be working together, including Long Island, Queens, Brooklyn, Manhattan, and Westchester County, to coordinate resources and take care of COVID-19 patients. In addition, some volunteer organization, non-governmental, have organized some additional ICU beds in Central Park in 48 hours. Again, in 48 hours, the Javits Center, which is one of the largest convention centers in New York City, has been turned into a hospital by the United States Army that in 48 hours has built 1,700 additional beds. And this is always for COVID-19 positive patients. In addition, the idea would be that trauma patients that would be COVID negative would have a safe hospital to be taken care of. That would be the naval hospital ship called Comfort, which was brought to the harbor of New York City, namely to take care of COVID negative patients, as you can see on the images. Now, a few numbers. I apologize for the slide not to be sharp, but basically this is a trend of number of hospitalizations. Each bar represents 1 day from March to April. At the apex, you can see about over 3,000 hospitalizations per day. And you can see on the far right, on April 30th, it's about slightly over 900 hospitalization per day. A few concepts we may not think much about it in surgery is the concept of aerosol, also known as air solution of particles. This is important as it goes back to the concept of droplets, which is how the coronavirus is expected to spread. And you can see on the next slide the size of these particles. It's important because it reflects also the content of these particles. They can be combustion particles. This is applicable to the use of monopolar or bipolar energy in the operating room, or what we generally call mist from the ultrasound dissectors that are used in open and laparoscopic surgery, but also bacteria, viruses, and others. Now, there is too much to say about the behavior of these particles. I'm just going to say a few words about settling, And all these data are coming from the Center for Disease Control, the CDC in the United States. The size of the particle matters. As you can see, the range goes from over 40 hours to just a few seconds, depending on the size of the particle. And this is in still air. Then if you consider in a closed room the difference between stagnant air and turbulent air, you will see there are differences that I'm not going to go into detail for, but this is very important to understand safety in the operating room under these circumstances. Again, in turbulent air, you can see also the range of half-life of particles ranging from 0.5 micrometers to 100 micrometers. Now, the decisions made about handling colorectal cancer patients have changed during this time, and particularly when it came to chemotherapy, particularly adjuvant or neoadjuvant, these patients have been recommended to halt and take a break from their chemotherapy due to the risk of COVID-19 infection. A number of measurements, a number of measures have been implemented in the operating room to perform emergency colorectal surgery. As you know, any elective colorectal surgery has been placed on hold. We're going from the written consent to verbal consent only, testing preoperatively the patients whenever possible for antigen and antibody, doing a chest CT scan, pay attention particularly immunocompromised, like in the hospital where I work. We have a lot of transplant patients. So in those cases, keeping immunosuppression to a minimum, the so-called PPEs, the personal protective equipment, the disinfection, using stenting for obstructed cancers, making sure that the patient has an N95 respirator whenever the patient is being transported, controlling glucose to prevent hyperglycemia post-op, and particularly pay attention to the disseminated intravascular coagulation, so checking on the coagulation profile. We are operating in negative pressure operating rooms, and we are really mitigating traffic in and out, so the doors are basically shut. We use liberally suction, filtration during intubation, extubation. Every operation is done through a laparotomy, no laparoscopy due to the risk for viral transmission. We are not using any energy devices such as cautery, bipolar energy, ultrasound, just sharp dissection with cold instruments like knife and scissors, suture ties, suture ligations, like in the old days. We use closed system for irrigation and suction, of course. Everything is disposable, wound protectors, specimen bags. The specimen are handled with protective measures. We are very selective using ostomies due to the research that's been proving that coronavirus is present in stool, however, not in urine, as far as we know for now. We are not using ostomy rods, otherwise there will be a risk for viral transmission to the enterostoma nurses or any other nurses or personnel attending to the ostomies. We are encouraging the use of smart bags for ileostomy because they allow remote monitoring of output, prevention of dehydration, acute kidney injury. All it takes is basically an app in an iPhone. We avoid drains if possible, For wound therapy, we use negative pressure. We do chest x-rays or CT scan post-operative of the chest. We consider early discharge to COVID-19 facility. And for follow-up visits, we use telemedicine. These are examples of the VAC, negative pressure wound dressing that we use. They can be kept on for 5 days. This is an example of the app for a ileostomy remote monitoring. When it comes to the pandemic, you have to distinguish an epicenter like New York City from a non-epicenter. This article is basically discussing the fact that robotic surgery has no role in an epicenter like New York. However, in a non-epicenter, robotic surgery may be considered for specific operation, and particularly rectal cancer. I'm sure you have heard about the epidemiological models to forecast or project deaths. This is a model that's one of the models that have been studied from Columbia University in Manhattan. And if you look at the far right, you can see that projected mortality would be ranging from a minimum of 60,000 to over 300,000. We are right now just past 60,000. As you can see on this picture, there has been mass grave in New York City during the pandemic. When I drive home, I can see this sign. It reminds me where New York's tough, and the Statue of Liberty saluting the hospital ship. Thank you very much for listening.